Hi guys. Hi guys. So I'm Rintu Roy. I'm faculty of Pharma International Institute. So today we are going to study about the drugs acting on GIT. Drugs acting on GIT. This is our basic lecture of the day. So now we are going to the drugs acting on GIT. What is GIT? Let's go to GIT, gastrointestinal tract. So before going to the drugs that is acting on GIT, it is very necessary to study about the basic gastrointestinal system. So here you can see the digestive system, what all it contains. So the digestive system is starting from our mouth, and that is going to the salivary glands, esophagus, that is leading to the small intestine, then to the large intestine, and then rectum, anus. This is basic. So here, what are the parts of the digestive system? It is clearly mentioned here that a mouth, tongue, salivary glands, pharynx, larynx, esophagus, stomach, pancreas, spleen, liver, large intestine, small intestine, and anus. These are the basic digestive system. So the mouth, that is, and tongue, and that is leading to the salivary glands. Actually, there are three types of salivary glands. So what are the three types of salivary glands? That is parotid gland, sublingual gland, and submandibular gland. So what are the three types of salivary glands? That is parotid gland, sublingual gland, and submandibular gland are the three types of salivary glands. And then pharynx, that is a throat, and larynx. What is larynx? Larynx is our vocal box, that is the sound box. And our esophagus, stomach, pancreas, spleen, liver, large intestine, small intestine, and anus. Even we know that the small intestine has three parts, that is duodenum, jejunum, ileum. What are the three parts? That is duodenum, jejunum, and ileum. So from here we know that the duodenum is the first part, and it as a whole, if we say about small intestine, it is the one which is having the largest surface area, and about 60% of our drugs are being absorbed in the small intestine area. And large intestine is further, we can see that is colon, rectum, and anus. It can be further be divided as colon, rectum, and anus. And also from here we can say something about the liver. Liver is known as the detoxifying organ. Because why that is known as the detoxifying organ? Because it can detoxify, or it can manage many chemicals. So that is why the liver is known as the detoxifying organ. So this is the basic digestive system. And we have to be very thorough about one thing, that is mucosa, the mucosal layer. Okay? What is the mucosal layer? What is mucosa? That is, mucosa is the layer which protects our entire GIT. That is even starting from our esophagus, and that is lining our entire GIT. So what this is doing is, this is protecting our GIT. So this mucosal layer is very important for the protection. Why the mucosal layer is important? It is very important for the protection of our GIT. Okay? Now we can study about basic terms, basic diseases, what are happening. So we know that mucosa is the protective layer. So peptic ulcer, what is peptic ulcer? Peptic ulcer is actually a group of disorder that is characterized by any lesions of the mucosa layer. If there is any lesion to the mucosa layer, that is known as the peptic ulcer. That is being resulting into the open sores, excessive hydrochloric acid is producing, and that is resulting in the open sores, and this is leading to this peptic ulcer condition of the, mainly it is affecting in the upper gastrointestinal tract portions, that is peptic ulcer. And in also peptic ulcer condition, there will be an excess of gastric acid secretion, and our mucosal layer cannot defend against this. That means our mucosal layer cannot act to protect, and that is a condition that is leading to the peptic ulcer. So what is peptic ulcer? It is a group of disorders characterized by lesions of the upper gastrointestinal tract. Next one is gastroesophageal reflux disease, which is also known as GERD. What is gastroesophageal reflux disease? This is actually a very serious condition. That means it refers to the retrograde movement of the gastric contents from the stomach to the esophagus. It is a retrograde movement. That means moving backward. Actually, we have valves to prevent this retrograde movements. But in case If there is a retrograde movement of the gastric contents from the stomach to the esophagus, so that particular condition is known as the gastroesophageal reflux disease. Next one we can talk about dyspepsia. So what is dyspepsia actually? Dyspepsia is indigestion. What is dyspepsia? Dyspepsia is indigestion. So in dyspepsia condition, we have indigestion, and that is being accompanied by persistent pain, abdominal cramps. These type of symptoms we can see in dyspepsia condition. So what is dyspepsia? It is indigestion that is accompanied by persistent or recurrent abdominal pain, abdominal discomfort that is centered in the upper abdomen. This is dyspepsia condition. Next one is stress ulcers, stress associated ulcers. So, as the word suggests, how the stress ulcers is happening? That is due to some sort of stress that is resulting from any major accidents, trauma, or something like that. In all these conditions, we experience the stress ulcers that result from serious trauma or illness, major burns. So, in such a conditions, we will be experiencing stress ulcers. And in such a stress ulcer condition, we need mechanical ventilation for 48 hours. We need mechanical ventilation for about 48 hours. Okay. So these are the general terms. Now we can go to some other serious condition, that is the Zollinger-Ellison syndrome. What is that? Zollinger-Ellison syndrome. Zollinger-Ellison syndrome is actually, it's a severe form of the peptic ulcer disease. It's a very, very severe form. So in this particular condition, what is having, there will be an extreme secretion of the hydrochloric acid. Hydrochloric acid will be in enormous amount, and that is accompanied by a gastrinoma. Gastrinoma means what? That's a non-islet cell tumor of the pancreas. That is the gastrinoma. Okay. So there will be an extreme hypersecretion of the hydrochloric acid, and that is being accompanied by a non-islet cell tumor of the pancreas, and that is known as gastrinoma. Okay, that is Zollinger-Ellison syndrome. So that is a very serious complication. It's a hypersecretion of this hydrochloric acid. Okay. Next one is drug-associated ulcers, or we can say this as NSAIDs-associated ulcers. Okay. So what is this NSAIDs-associated ulcers? So if this particular ulcers are coming when we are using a lot of particular drug, especially if you are using chronic, due to a chronic use of an NSAID, this may result. This is occurring in the patients who chronically ingest substances that damage the gastric mucosa, such as NSAID. So we are calling it as NSAID-associated ulcers. So that is drug-induced ulcers or NSAIDs-associated ulcers. And when we come to the ulcers, we can say that there are two types of ulcers, that is duodenal ulcers and gastric ulcers. There are two types we can see, that is the duodenal ulcers and gastric ulcers. And from the figure, it is clear that we can see this is a stomach figure. And from the stomach figure, when this open source, when the lesions of the open source are present in this gastric area, that is the gastric ulcer. Here we can see the small intestine duodenum portion. So in this duodenum portion, can you see this source here? So when the source are coming in the upper portion of the small intestine, that is the duodenum portion, that is known as a duodenal ulcer. That is known as the duodenal ulcer. Okay. Now, our common disease and terms are over. Now we can deeply go to the peptic ulcer portion. So what is peptic ulcer? Peptic ulcer actually, as we said, that our inadequate mucosal defense against the secretion of the hydrochloric acid is resulting to the peptic ulcer. So what are the main two causes of this peptic ulcer? As we know that, yes, NSAID, chronic use of NSAIDs can cause this peptic ulcer. But the major causative organism is gram-negative Helicobacter pylori. Gram-negative H. pylori, that is known as the Helicobacter pylori, and that can affect into the peptic ulcer disease. And as we said, yes, the use of this non-steroidal anti-inflammatory drug, that can also result in this peptic ulcer condition. So increased hydrochloric acid secretion, yes, we said that increased hydrochloric acid secretion, hydrochloric acid is secreting in an enormous amount, but even though in a normal condition, if hydrochloric acid is being secreted, what happens is our mucosa can defend against this. But in a peptic ulcer conditions, what? Inadequate mucosal defense. The mucosa cannot they cannot give adequate defense. That is an inadequate mucosal defense against the gastric acid. So this is the main peptic ulcer disease problems. These are associated. And what is the treatment approaches? How the treatment approaches? First one, as we said that yes, which is the causative organism? It's important to know the causative organism, that is gram-negative H. pylori. So that is the causative organism. So what we have to do is we have to eradicate this particular H. pylori, that is gram-negative H. pylori. So the eradicating the H. pylori infections. And the H. pylori, this particular bacteria can colonize in the stomach. They can colonize, that can lead to the severe gastric inflammations, and that is mainly known as the gastritis conditions. They can lead to such a condition. This Helicobacter pylori, H. pylori, is the causative organism for this peptic ulcer. So we have to, first treatment approach, we have to eradicate the H. pylori infection. Second one, reducing the secretion of acid with the use of proton pump inhibitors or H2 receptor antagonists. So what this proton pump inhibitors and H2 receptor antagonists are doing, they will help to reduce the gastric acid segregation. So we can use these type of oral drugs for this particular conditions. And next one, we can provide the agents that protect the gastric mucosa. Even though the hydrochloric acid is being secreted, we can protect our mucosa by giving some agents like the sucralfate, misoprostol. In such a conditions, we can protect like that. So that is providing the agents that protect the gastric mucosa from damage, that is misoprostol and sucralfate. And what is misoprostol? It's a prostaglandin analog, and sucralfate is a cytoprotective agent. It's a mucosal protective agent. Okay. Next, we can go to an important pathway, that is the arachidonic acid pathway. What is arachidonic acid pathway? Arachidonic acid pathway is actually an inflammatory pathway. What is arachidonic acid pathway? It's actually an inflammatory pathway. So, how these inflammatory pathways are happening? So, let's look at it. Now, this is the membrane phospholipids, where the membrane phospholipids are present mainly in our cell membrane. So when the PLA2, what is PLA2? That is phospholipase A2. When the PLA2, that is a phospholipase A2, is acting on the membrane phospholipid, it will be converting into the arachidonic acid. And arachidonic acid is actually a fatty acid. And this arachidonic acid is actually following two pathways here. That is, one is the LOX pathway and another one is COX pathway. LOX pathway is lipooxygenase pathway and COX pathway is cyclooxygenase pathway. So they are the LOX pathway, they are being HPETE. HPETE is hydroxyperoxyicosapentaenoic acid. So this HPETE is being leukocytes and leukotrienes. Now we can go to the COX pathway. Through the COX pathway, they are forming the cycloendoperoxidases. And cycloendoperoxidases is further forming platelets, that is thromboxanes, endothelium, that is prostacyclin, and smooth muscles that is prostaglandin. So this is mainly our COX pathway. When we are giving the NSAIDs like aspirin, what happens is they have the ability to block this particular COX pathway. Understood? So when we give this NSAIDs like aspirin, what happens is they have the ability to block this COX pathway, then the LOX pathway will only work in such a condition. Okay. That is the basic arachidonic acid pathway. Next, we can go for the classification or the drugs for the peptic ulcer disease. So drugs for the peptic ulcer disease, in first, we have seen that is the gastric acid secretion inhibitors. Which are the gastric acid secretion inhibitors? H2 antihistamines. H2 antihistamines, we are usually using this, but this use of this H2 antihistamines is not wide today because of the evolution of the proton pump inhibitors, and also the H2 antihistamine is having a lot of side effects. So nowadays we are going for the proton pump inhibitors. So what are the drugs coming under the H2 antihistamines? That is cimetidine, ranitidine, famotidine, roxetidine, and anticholinergics, that is pyrazine, propanthelin, and oxyphenonium. Proton pump inhibitors, this more widely used one, this is omeprazole, esomeprazole, pantoprazole, lansoprazole. These are the commonly used proton pump inhibitors, and prostaglandin analog, as we said, that is misoprostol. And gastric acid neutralizers, which are the neutralizers? So that can be systemic neutralizers like sodium bicarbonate, sodium citrate, and non-systemic like the magnesium hydroxide, magnesium trisilicate, aluminum hydroxide, megaldrate, and calcium carbonate. These are the gastric acid neutralizers. Then we are going to the ulcer protectors. So what are the ulcer protectors? That is sucralfate and CBS, that is colloid bismuth subcitrate, and anti-H. pylori drugs, that is the drugs which are anti-H. pylori. Causative organism is H. pylori. Anti-H. pylori is working against this H. pylori. What are the drugs? That is amoxicillin, clarithromycin, metronidazole, tinidazole, tetracycline, and CBS. These are coming under the anti-H. pylori drugs. So this is the basic classification of the drugs for the peptic ulcer disease. Next, we are going to study about the H2 antihistamines. So basically, H2 antihistamines, we have H1 receptors, H2 receptors, and histaminic receptors like that. But H3 receptors and H4 receptors, but H2 antihistamines is mainly acting on the H2 receptors, and H2 receptors are mainly found in our GIT. So that should be acting to the H2 receptors selectively. Then only we will get the desired effect we need. So if they are, that is why they are H2 antihistamines. They are acting against the H2 receptors. So what are the actions? Actually, they are, yes, as we said, they are acting selectively on H2 receptors. They will be acting in the H2 receptors in stomach, and they have no effect on the H1 receptors. And what are the therapeutic uses? Yes, of course, we'll be using for the ulcers, right? So the peptic ulcers, we can give this for this peptic ulcers. First use is the peptic ulcer, and I have already said that the use of the agents has decreased with the advent of the proton pump inhibitors. Okay, now widely we go for proton pump inhibitors rather than going for the H2 antihistaminic. So they're effective in promoting the healing of the duodenal and gastric ulcers. There are two types of ulcers, as we said, that is the duodenal and gastric ulcers. And however, if H. pylori is present, the recurrence is always present. So the patient is treating, if we treat this patient with only this agent, the recurrence is very common. So that is, if the recurrence is common, if H. pylori is already present and we are treating alone, then recurrence can be seen. Then patients with NSAIDs induced ulcer should be treated with proton pump inhibitors. Okay, especially if the patient is having NSAID induced ulcers, we are going for proton pump inhibitors because they can heal and prevent the future ulcers more commonly than that of this H2 antagonist too. Okay. Next one is the acute stress ulcers. How the acute stress ulcer is coming? That is from some sort of accidents or traumas or severe burns or something else. In such a condition, we can experience the acute stress ulcers. So how the stress, they are in acute stress ulcer condition. How the drugs are given? As an intravenous infusion. How we are giving this? As an intravenous infusion to prevent and manage our acute stress. And also in high-risk patients, especially in the intensive care units patients, we can give this as an IV infusion. Then, however, tolerance may occur with these agents. There will be a development of the tolerance if we give these agents. So, we are going for the proton pump inhibitors more commonly nowadays. Proton pump inhibitors, okay? So, next one is the gastroesophageal reflux disease. We have said, what is gastroesophageal reflux disease? It is a retrograde movement of the gastric contents to the esophagus. That is a gastroesophageal reflux disease. So in such a condition, H2 receptors act by stopping the acid secretion. So always they are decreasing the acid. So in GERD conditions, if we give this H2 antihistamines, how they are acting? They are acting by stopping acid secretion, and they may not relieve the symptoms for about 45 minutes. They'll be acting only after a 40. There is a lag for their action. So in emergency conditions, if you are taking this type of drugs, is it beneficial? No, because why? Because they are taking 45 minutes. So in such a condition, if you are giving antacids, they can neutralize the stomach acid more quickly. Okay, but there is also a problem with the antacids, because why? They are having a short duration. They will give the effect in a short duration of action, but they are not long lasting. They can act quickly, but they are not long lasting. So we cannot take this antacids also. So antacids are more quickly and efficiently neutralizing the stomach acid, and their action is only temporary. So in case of this antacid, what is happening? The action is only temporary. So for these reasons, we are now preferring for the proton pump inhibitors. We are doing? We are preferring for the proton pump inhibitors. Okay. In the treatment of GIT, especially in the patient with severe heartburn, we go for this proton pump inhibitors. Okay. Next is the adverse effects. Adverse effect, yes, cimetidine is a H2 antihistamine. So what are the adverse effects? The endocrine effects are the gynecomastia and galactorrhea. Gynecomastia is the enlargement of the breast, and galactorrhea, that is the leakage of milk from the breast, that is the galactorrhea condition. So these can be an adverse effect of this cimetidine. And also the second adverse effect is the cimetidine is an enzyme inhibitor. What do you mean by inhibitor? What do you mean by inducer? The inhibitor are the drugs which can induce some particular enzymes, CYP enzymes. So the CYP enzymes are very important for the metabolism and the elimination. So if the CYP enzyme is being inhibited, actually cimetidine is an enzyme inhibitor. So they have the ability to inhibit the particular CYP enzyme. So CYP enzymes, if there is no CYP enzyme, there will be no metabolism and there will be no elimination taking place. So what happens? The drug which is given along with the cimetidine is being accumulated, and that is being into a toxic level. That is the meaning of inhibitor. So what happens? Inhibit several cytochrome P450 enzymes. So if we are taking cimetidine with any other drugs, they have the ability to inhibit the CYP enzymes and inhibit the metabolism of the other drug, and such that the drug will accumulate. So in case if it is an inducer, what is happening? It has the ability to metabolize and eliminate quickly. So the desired effect will not be achieved with an inducer. But in case of this cimetidine, it's actually an inhibitor. And they can interfere with the metabolism of many other drugs such as warfarin, phenytoin, clopidogrel, and such drugs. And all the H2 antagonists may reduce the efficacy of the drug that require an acidic environment for the absorption. So in case of ketoconazole, what they are saying is, ketoconazole always require an acidic environment for its absorption. So in gastric, in peptic ulcer conditions, we are giving the H2 antihistaminics. After giving the H2 antihistaminics, what is really happening? They will reduce the acidic environment of the stomach. So ketoconazole actually requires an acidic environment for its absorption. So if ketoconazole is given with H2 antihistamines, they can interfere with the acidic environment. They can interfere with the absorption of the ketoconazole. So these both drugs cannot be given together. Okay. Next, we are going to the proton pump inhibitors. These are the most commonly used drugs today, that is proton pump inhibitors. So how the proton pump inhibitors are acting? So suppose this is the parietal cells. Okay, this is the H plus K plus ATPase enzyme. So before going to that, how hydrochloric acid is secreted, that we have to understand. Actually, hydrochloric acid is secreted from the parietal cells. Which cells? Parietal cells. Okay. The parietal cells actually secretes H plus, and it will combine with the chloride and it forms the hydrochloric acid. Likewise, the hydrochloric acid is being secreted. That is mainly happening from the parietal cells. So the H plus K plus ATPase enzyme is required for this proton formation, that is H plus formation. So when this proton pump inhibitors, when we give this proton pump inhibitors, actually this is the proton pump. So they will act here. So what happens? Their PPA bind to this H plus K plus ATPase enzyme system, that is the proton pump. They can bind to this particular system and they can suppress the secretion of this hydrogen ions. They will suppress the secretion of the hydrogen ion. So if hydrogen ion is not there, can they form this hydrochloric acid? No. So this proton pump inhibitor is actually binding with that of the H plus K plus ATPase enzyme. They can suppress the formation of this H plus ions. Understood. So the membrane-bound proton pump, that is the final step in the formation of the gastric acid. So likewise, the gastric acid is not produced in such a condition. So that is the proton pump inhibitors. What are the examples coming under the proton pump inhibitors? Yes, omeprazole, lansoprazole, dexlansoprazole, pantoprazole, rabeprazole. These are the examples which are all prazoles are coming under the proton pump inhibitors. Of this, the OTC drugs are omeprazole, esomeprazole, lansoprazole. They are available as the over-the-counter for short-term treatment of the GERD conditions. We can give this as a OTC drug. Okay. So now the actions of this particular proton pump inhibitors. Actually, first we have to understand the proton pump inhibitors are commonly prodrugs. What are prodrugs? Prodrugs means these are inactive drugs. What are they? Prodrugs are inactive. Inactive drugs, after ingestion, once it enters the body only, it gets activated and shows its action. So why we are giving it as an inactive drug or as a prodrug? Because if you are taking the active form, rapidly it will be degraded by the hydrochloric acid. So we are taking in a prodrug form. So it cannot be degraded by a hydrochloric acid or the acidic environment of the stomach. That's why we are mainly giving this as a prodrug. So these agents are prodrugs. And also they have an acid resistant enteric coating. Why the acid resistant enteric coating? To protect from their premature degradation of the gastric acid. And the coating is actually removed in the duodenum. Duodenum is having an alkaline atmosphere. So what is having? The coating is removed in the alkaline duodenum. And the prodrug, that is a weak base, is absorbed and transported to the parietal cells. This is mainly happening. So there they will be converted into its active form. That is, a prodrug is being converted into the active drug, and they form a stable covalent bond with the H plus K plus ATPase enzyme. So likewise, they are forming this H plus complex with that of this H plus K plus ATPase enzyme. And how much hours they will act? It takes 18 hours for the resynthesis of this particular enzyme. So till that time, the particular acid secretion is inhibited. So likewise, the proton pump inhibitor is acting. Next, one are the therapeutic uses. Yes, why proton pump inhibitors? We can use in all of the gastric GIT conditions. We can go for this proton pump inhibitors, like how there is the stress ulcer treatment and its prevention, that is prophylaxis, we can go for. Then GERD, that is gastroesophageal reflux disease, erosive esophagitis, active duodenal ulcer, pathological hypersecretory conditions. That the hypersecretory condition is Zollinger-Ellison syndrome. We have studied that. That is Zollinger-Ellison syndrome, in which a gastric producing tumor causes hypersecretion of hydrochloric acid. And also they reduce the risk of bleeding, because if we have an NSAID induced ulcer, there is always the risk of bleeding. So this proton pump inhibitors can also reduce the risk of bleeding of ulcers that is caused by this aspirin or any sort of other NSAIDs, and may be used for the prevention and treatment of the NSAID induced ulcers. In the NSAID induced ulcers, we can go for this proton pump inhibitors, and they are used with antimicrobial regimens to eradicate the H. pylori. So to act against the H. pylori, we can use this proton pump inhibitors with antimicrobial regimen. So this is the PPIs, and always we use this PPIs as a superior drug to that of the H2 antagonist. We are preferring first for this proton pump inhibitors in suppressing this acid production and healing the ulcers. Okay. Next, the pharmacokinetics. As we know that for the particular acid reflux, we are taking always this drugs before food. That should be about 30 to 60 minutes before food. We are taking 30 to 60 minutes, that is before breakfast or the largest meal of the day. That likewise, if we take only, we are getting the maximum effect. For this maximum effect, we are taking this 30 to 60 minutes before the breakfast or before the largest meal of the day. All of the agents, and also these agents are very, very effective orally. They can be effectively taken orally. So esomeprazole, lansoprazole and pantoprazole, these are also available as an intravenous formulation. How it is available? These are available as an intravenous formulations. Next one is the adverse effects. What are the adverse effects coming under this? That is omeprazole and esomeprazole, they can decrease the effectiveness of the clopidogrel. How? Clopidogrel is actually an anti-platelet medication. So we know that clopidogrel is active. Clopidogrel has an active form. It has an active metabolite, okay? So, in order for the conversion of this clopidogrel to its active metabolite, actually we need the CYP2C19. Okay, what we need? CYP2C19. So, clopidogrel is actually an inactive form. In order to convert to its active form, we need CYP2C19 for this particular conversion. So, omeprazole and esomeprazole, what they are doing is they decrease the effectiveness of this clopidogrel by inhibiting the CYP2C19. They can inhibit this particular CYP2C19 and they will prevent this particular conversion of the clopidogrel to its active metabolite, and this is mainly happening. And PPIs may increase the risk of fractures. Next one, they can increase the risk of fractures because how? They can decrease the absorption of calcium. What is? They can decrease the absorption of calcium. So thereby, they will decrease our bone mineral density. What happens if the bone mineral density is decreased? That will lead to this osteoporosis and the osteoporotic condition, that was porous bone conditions, and also they can increase the risk of fractures, and these types of problems are mainly affected. And next one, diarrhea and Clostridium difficile associated colitis may occur in the community patients receiving this proton pump inhibitors. And additional adverse effects are hypomagnesemia. This is important, that is, it is hypomagnesemia. With all of this proton pump inhibitors, it is very important to remember that they can cause the hypomagnesemia and an increased incidence of pneumonia. So these are the adverse effects coming under the proton pump inhibitors. Now we are going for the prostaglandins. What are prostaglandins? Prostaglandins are, we have seen the prostaglandins especially in the arachidonic acid pathway. We have seen the prostaglandins. So how the prostaglandins are actually helping us? Actually, prostaglandins can decrease the acid production. They can stimulate the secretion of the mucus and the bicarbonate. Okay, how they can stimulate the secretion of mucus and bicarbonate, and they can decrease the secretion of acid. The main action of prostaglandin, how they can decrease the action of, they can inhibit the action of this particular acid, and they can increase the secretion of the mucus and bicarbonate, and that particular effect, that is a cytoprotective effect. What is that? That's a cytoprotective effect. Okay, so that is a cytoprotective effect. So that is the main action of the prostaglandins. They can suppress the acid production, increase the mucus and the bicarbonate production, that is eventually helping in the peptic ulcer conditions. And misoprostol. Misoprostol is a prostaglandin analog. What is misoprostol? It's a PGE1 analog. We used to say that. So misoprostol is a prostaglandin analog. So this can be given, especially in NSAIDs associated ulcers and conditions. We can give as a prophylaxis to prevent this particular thing. As a prophylaxis, we can give this. We can go for the misoprostol. And the important one to know about misoprostol is the misoprostol or the mifepristone. That combination mainly they increases the uterine contractions. When they increase the uterine contractions, they can cause abortion. So this is not recommended for the pregnant women, but we can give to induce labor at the end of the pregnancy during the delivery. In order to induce the labor, we need this uterine contractions. In such a conditions, we can go for the misoprostol. So, misoprostol is an analog of prostaglandin E1. It is approved for the prevention of NSAID-induced gastric ulcers. And prophylactic use of misoprostol, that should be considered in all of the patients who are taking NSAIDs. And at moderate risk to high risk NSAID-induced ulcers, as a prophylaxis, as I said, we can give it. And it is contraindicated in the pregnancy because it can stimulate the uterine contractions and can cause this miscarriages. And dose-related diarrhea and nausea. Okay, next one. Dose-related diarrhea and nausea, they are the common adverse effect, and we have to limit the use of these agents because of these type of side effects. Next, we are going for the antacids. So what are antacids? So antacids are actually weak bases. What we have to say, they are weak bases. So what reaction that is mainly if in a hypersecretion of hydrochloric acid condition, if we are giving this basis, what is happening? So this weak basis is actually acting with that of the gastric acid, and they form water and salt. They form water and salt. That is the reaction mainly happening if we give antacids in the peptic ulcer condition. So what is happening? Antacids are actually weak bases and they react with the gastric acid. As we said, they bases, they react with this acid, they form this water and salt. What they are forming? Water and salt. Likewise, they will diminish the gastric acidity. That particular reaction helps to diminish the gastric acidity. And pepsin. We know what is pepsin. Pepsin is actually a digestive enzyme, or we can say that it's a proteolytic enzyme. So what this peptin is actually doing? They break down the proteins into amino acid and small peptides. So they will break down protein to amino acid and peptides. So these are breaking down of proteins to amino acids and peptides. And pepsin is showing its most of this activity in the acidic environment. So in the acidic environment, pepsin is very active. So actually in an ulcer-like condition, the activity of the pepsin is very dangerous because already our mucosal layer is completely eroded. In such a condition, the pepsin will, that there will be an acidic environment. So as if there is an acidic environment, the pepsin is something which is very active in this acidic environment. So it will come to the underlying tissues of this mucosal layer and they will digest the proteins of that particular tissues, and that can worsen the ulcer conditions more. So the activity of the pepsin is not very good in an ulcer condition. So in PUD, the mucosal lining of the stomach and duodenum is damaged, and that is allowing the pepsin to come in contact with this underlying tissue. And pepsin can digest this particular proteins, leading to further damage and ulceration. So if we are giving an antacid in such a condition, this antacid has the ability to reduce the activity of the pepsin also. Okay, antacid can reduce the pepsin activity also. Commonly used antacids, which are the commonly used antacids here? Combination of salts of aluminium and magnesium. So why we are giving aluminium and magnesium as a combination? Yes, aluminium is causing constipation and magnesium is causing diarrhea. So, in order to specify each other's effects, we are giving the aluminium and magnesium as a to prevent this constipation and this diarrhea. We can give this as a combination. They help to specify each other's effects. So we can give in such a condition, ulcer conditions, we can give it as a combination. That's an antacid, as aluminium hydroxide and magnesium hydroxide. Okay. Then calcium carbonate is a antacid, and sodium bicarbonate NaHCO3, that's also an antacid. Next is mucosal protective agent. What is a mucosal protective agent? As the name says, that is something to protect our mucosa, that helps to protect our mucosa. So that's why they are also known as the cytoprotective agent. What we call it as mucosal protective agents are also known as the cytoprotective agent. So one common example of this particular one is sucralfate. So what is sucralfate? Sucralfate is actually a complex of aluminium hydroxide and sulfated sucrose. It's a complex of aluminium hydroxide and sulfated sucrose, that is sucralfate. And where this is acting, actually this particular sucralfate is acting to the positive charge of the mucosa, whether it is a necrotic mucosa or the normal mucosa, it doesn't matter. It will they'll bind to this positively charged group in proteins of both normal and the necrotic mucosa, and they will form a complex gel. They will bind to the positive charge of the proteins and they will form a complex gel, and they will create a physical barrier likewise, and that protect the ulcer from pepsin and acid and allowing this ulcer to heal. Likewise, the sucralfate is acting as a cytoprotective agent. Next one, although the sucralfate is very effective for the treatment of duodenal ulcer and also for the prevention of the stress-induced ulcers, the use is actually we are not using this cytoprotective agents much, because if we are giving this, we need multiple daily dosing. In order to avoid this multiple daily dosing, and drug to also it has drug interaction. So such because of these type of problems, we are not frequently using it. And because it requires an acidic pH for the activation, sucralfate should not be administered with PPIs, H2 antagonists or antacids, because they always need an acidic environment to act. If we are giving these drugs, the acidic environments will not be there. That's why we are not giving together with those type of drugs. Next, we have said that proton pump inhibitors, in order to eradicate the H. pylori, we can give with some sort of this antibiotic. So this is actually leading to a triple drug therapy and a quadruple drug therapy. So the triple drug therapy is mainly, so the triple drug therapy is actually we can give a proton pump inhibitor plus clarithromycin 500 mg plus amoxicillin 1 gram. This is the main triple drug therapy. What is that? Proton pump inhibitors, for example, that is omeprazole. Standard dose is actually 20 gram. So sorry, 20 mg. So we are giving for this proton pump inhibitor plus clarithromycin 500 mg plus amoxicillin 1 gram. This is a major triple drug therapy. If this particular amoxicillin is not working, we can substitute this amoxicillin with metronidazole 500 mg. Okay, we can go for metronidazole. So that will be then proton pump inhibitors plus clarithromycin plus metronidazole. That will be another triple drug therapy. If the triple drug therapy is not working, in such a condition, what can we do? What can we go for? We can go for the quadruple therapy. In such condition only, we are going for the quadruple therapy. So what are coming under the quadruple therapy? That is proton pump inhibitor plus bismuth subsalicylate plus metronidazole plus tetracycline. This is the major quadruple drug therapy. And we know that this is a combination. So we must not substitute this particular drug with any other drug. For example, we know that amoxicillin, ampicillin, these are coming under the same category, same classification. So if amoxicillin is not working, can we substitute with this ampicillin? No, we are not supposed to substitute this particular combination with. Yes, we said that if amoxicillin is not working, we can go for metronidazole. Rather than this, no drugs are supposed to be substituted with any of the drugs coming under this combination. So substitution of antibiotic is not recommended. Understood? Next is antiemetics. So we know what is emesis. Well, we know about emesis. What is emesis? Emesis is actually vomiting, right? Emesis is actually vomiting. How vomiting is occurring? Because that is mainly, we know that CTEZ, chemoreceptor trigger zone, right? So vomiting is occurring due to the stimulation of any of the receptors. We have many receptors. There are 6 types of receptors involved. Which are they? H1 receptors, M3, M5 receptors, D2 receptors, 5HT3 serotonin receptors, NK1 receptors, cannabinoid receptors, that is CB1 receptors. There are different types of receptors that are present. So any of the receptors get stimulated, any of the vomiting receptors get stimulated. This stimulation is going to the vomiting center. This vomiting center is getting that stimulation. This vomiting center is actually connected to the chemoreceptor trigger zone, and that is mainly in the medulla oblongata of the brain. In that particular zone, is due to the multiple pathways, multiple ways of stimulation of this chemoreceptor trigger zone, vomiting is occurring. So antiemetics, that means something which is to act against this particular emesis, that is antiemetics. We can give this antiemetics to control this particular vomiting. So let's see which are the antiemetics drugs. So classification of the antiemetic drugs. Which are the drugs coming under the antiemetics? First one is anticholinergics. So what are the anticholinergics? Yes, hyoscine and dicyclomine. Next one, the anti-H1 antihistamine. So where H1 antihistamine is mainly acting against the H1 receptors. Which are the drugs which are coming under this? That is promethazine, diphenhydramine, dimenhydrinate, doxylamine and the meclizine. And next one is neuroleptics. Which are the drugs coming under the neuroleptics? That is chlorpromazine, triflupromazine, prochlorperazine. And next one is the prokinetic agents, which are the drugs coming under the prokinetic agents, that is metoclopramide, domperidone, cisapride, mazapride, and etopride are the drugs which are coming under the prokinetic agents. And next one is the 5-HT3 antagonist. This is actually very common in today's market, that is ondansetron, granisetron, palanosectron, ramosetron are examples of the 5-HT3 receptor antagonist. Next one, NK1 receptor antagonist, that is aprepitant and fisaprepitant are examples for that. Next is adjuvant antiemetics, which are the drugs coming under the adjuvant antiemetics, that are dexamethasone, benzodiazepine, dronabinol, and nabilon. So these are the main antiemetic drugs, the drugs which are acting against the MSS. And also we know that the hyoscine, they can be also used in the motion sickness. Okay. Next is anti-diarrheal. So how this diarrhea is happening? How diarrhea is mainly causing? Because that is due to the excessive motility of the GIT. Increased fluidity of the stools is actually watery stools. That is the main thing which can see the diarrhea, right? Decreased absorption of the fluid. There will not be having an enough absorption of the fluid. So what is the main causes? Main cause is actually increased motility and decreased absorption of the fluid. So in such a condition, we can first go for an ORS. ORS is something very common and it's very safe also. What are the contents of this ORS? That is sodium chloride, potassium chloride, sodium citrate or sodium bicarbonate, glucose and water. These are the contents of this ORS formula. And mainly why we are we are adding the sodium citrate in this ORS formula. That is, sodium citrate is very important, very effective to prevent this acidosis. In such a condition, we can add this sodium citrate. That's the use of it. Okay, next one is the inflammatory bowel disease. So it's a bowel disease, inflammatory bowel disease. So inflammatory bowel disease is actually, it's a group of chronic diseases or disorders that mainly causes the inflammation of the intestines. Okay, that is mainly causing the inflammation of our intestine. That's why we're getting this inflammatory bowel diseases. And it occurs when the body's immune system attacks our healthy bowel cells. We have healthy bowel cells and our body's immune system is attacking our healthy bowel cells. So that's why we are getting the inflammatory bowel disorders. They causes the swelling and also other damages. So that is known as the inflammatory bowel disease. And we can see there are two types of this inflammatory bowel disease, that can be ulcerative colitis and also Crohn's disease. Okay, ulcerative colitis and the Crohn's disease. So suppose, what is ulcerative colitis and what is Crohn's disease? Suppose, okay, we can understand the difference of both of this. So suppose this is the large intestine and this is the small intestine. So in ulcerative colitis, what is happening is there will be a uniform inflammation. This will be the inflammation. Okay, the inflammation will be uniform. Ulcerative colitis, that is uniform inflammation. Okay, when it is a case of the Crohn's disease, what is happening? Inflammation will be patchy here and there. Okay, the patchy inflammation, that is the Crohn's disease. So in ulcerative colitis, what is happening? There will be a uniform inflammation like this, and in this Crohn's disease, what is happening? We have a patchy inflammation, so which will be more easier to heal. That will be the ulcerative colitis, because it is having a uniform inflammation. So more very easy to be treated is always, it will be the ulcerative colitis. Okay, what are the drugs which are coming for the diarrhea? Drugs which are coming are antimicrobial agents, which are norfloxacin, ciprofloxacin, rifaximin, clotrimazole, ampicillin, tetracycline, erythromycin, and metronidazole. And non-specific antidiarrheal agents are adsorbents, that is ispagula, methylcellulose, kaolin, pectin. This ispagula types, this is very important. And next one is the anti-secretory drugs are racecatrotil, CBS, anticholinergics, octreotide are important. Anti-motility drugs to prevent the motility. So we give the codeine, diphenoxylate, and the loperamide. And probiotics are lactobacillus species, bifidobacterium bifidum, streptococcus faecalis, and the enterococcus species. Next one, the drugs for IBD. Drugs for IBD are 5-amino salicylic acid compounds, which are the 5 amino salicylic acid compounds. They are sulfasalazine, mesalazine, all-salazine, valsalazine. These are the 5 amino salicylic acid compounds. Next one is the glucocorticoids, that is prednisolone, hydroxyprednisolone. Okay. Next one is the constipation. So your constipation is also an important disease condition. How the constipation is coming? Constipation means it's very hard for the gastric contents to move, right? That particular thing is actually resulting to the constipation. So we can commonly, in such a condition, difficulty to pass on, to move on this gastric contents, especially for the elimination, that will be very hard stools. So in such a condition, we can go for laxatives. So laxatives are very effective in such a condition. So laxatives are commonly used for constipation to accelerate the movement of food through the GI tract. What they are doing, they are actually accelerating the movement of the drugs through the gastrointestinal tract. And they also causes electrolyte imbalances when it is used chronically. So we are not supposed to use this chronically because they can cause the electrolyte imbalances. And many of the drugs have a risk of dependency to the user. Okay. Now, which are the drugs which are coming under the laxatives? We can go for that. That is bulk forming agents. That is dietary fibers, bran, psyllium, ispagula, methyl cellulose. When a pregnant lady is coming, we are first preferring for this dietary, this bulk forming agents like this dietary fibers. We can go for such type of drugs that is more safe in the pregnancy conditions. And stool softeners are actually, they are allowing water to enter into the stool. When water is entering into the stool, what happens? The stool becomes soft. It softens and it is easy to pass to this anus. So such a condition we can use for the stool softeners. And next one, the stimulant purgators. Stimulant purgators is actually, it is very dangerous to give to the pregnant ladies. They are not at all good for the pregnant ladies because they can cause excessive contractions. They can affect negatively to the child. So we cannot give stimulant purgatives. So which are the drugs coming under the stimulant purgatives? That is the diphenyl methanes, that is phenolphthalein, bisacodyl, and sodium picosulfate. Next one is the anthraquinones, that is Senna, Cascara, Sagrada. Next one is a 5-HT4 antagonist, that is prucalopride, and fixed oils are castor oils. Next one, osmotic purgatives. Which are the drugs coming under the osmotic purgatives? That is magnesium sulfate, magnesium hydroxide, sodium sulfate, and lactulose. Lactulose is actually in India, it is available as loose and all, right? We can see that the brand name. So these are all found. So this is the end of the chapter. So we have come across the peptic ulcer, the various gastrointestinal tract disorders, and our type of constipation, emesis, drugs for this, and diarrhea. So hope my session is very clear to everyone watching. So thank you so much for your patience. Thank you so much for your valuable time to listen to the lecture conducted by the Pharma International Institute. Thank you so much.